Hi, my name is Jim McKee. I'm a resident faculty member at Spear Education. It's a pleasure to join you for the Study Club module. At Spear Education, we talk about a comprehensive approach to treatment planning. And one of the topics that generates a lot of questions is developing a treatment plan for patients with injured jaw joints. The purpose of this Study Club module is to give you more confidence when you talk to your patients with injured jaw joints. So let's imagine it's Monday morning and the phone rings in your office. A 32-year-old new patient named Tracy calls your office because she's just moved to the area and her uncle referred her to you. Her uncle is one of your best patients who've just finished a major implant reconstruction for him, and he's very happy with the result. He has a great deal of confidence in you, and he referred his niece to you because he says you are the best dentist in town. She schedules her appointment for an exam, and she comes to see you the following week. Tracy comes into the office. She's a great new patient. You get along well with her. And basically, the exam is going well until she says, I need a night guard because I have TMJ. Can you make me a night guard that'll fix my TMJ problems? When you ask how long she's had the problem, she says she started clicking when she was in 6th grade. She doesn't click anymore because she can hear a grinding noise in her left jaw joint. So let's stop here. Let's talk about a couple of questions that are key to this case. The first question is, how do you talk to patients about clicking, popping, or jaw joints with a grinding noise? The second question I'd like you to discuss in the study club is, will a night guard be able to stop clicking joints or at least prevent the joints from getting worse? Let's stop here and have some discussion. Welcome back. In order to be able to talk to patients about clicking and popping joints confidently, we need to know what type of joint we're treating. So really, when it comes down to it, there's 3 main types of jaw joints that we see in clinical practice. The first type of jaw joint is structurally intact. Both the soft tissue comprising the disc and the hard tissue comprising the condyle and the joint socket are normal. This is illustrated from the top view in the image on the screen. The key anatomic factor in this case is that the ligaments that attach the disc to the condyle are structurally intact at both the lateral pole and the medial pole. Given the normal soft tissue and hard tissue anatomy in this joint, the risk profile is low. Now let's change our perspective from an indirect visualization through diagrams and use direct visualization through TM joint imaging to better understand the anatomy in normal TM joints. Our first view will be a side view or a sagittal view. The joint socket or the base of the skull is outlined in yellow. The brain is above the joint socket while the condyle and disc are below the joint socket. The condyle is outlined in red and the disc is outlined in blue. Now if we look at the anatomy, it becomes clear that the posterior attachment of the disc is approximately at the 1 o'clock position in normal jaw joints. Now let's take a look at a CBCT from the same perspective. Similarly, the joint socket's outlined in yellow and the condyle is outlined in red. The disc is not outlined since in CBCTs we can only see hard tissue. Now let's switch views and take a look at the anatomy from a front view or a coronal view. The first view we'll look at is an MRI. Again, the joint socket's outlined in yellow, the condyle's outlined in red, and the disc is outlined in blue. In the CBCT, the joint socket's outlined in yellow and the condyle's outlined in red. When we take a look at condylar size, the condyle is normally approximately 8 millimeters in an anterior-posterior dimension, and it should fill approximately 2/3 of the joint socket. The condyle is normally 20 millimeters in a medial to lateral dimension. A key point when looking at CBCTs is to understand in normal joints the cortical plate is going to be intact and the contour will be smooth and dome-shaped. Now you'll notice we've made a distinction between the lateral and medial pole of the joint. And that's necessary in order to be able to understand risk factors. So what we want to talk about for a couple of minutes here is the clinical significance of the medial pole. The more commonly known role of the medial pole has been related to the load-bearing portion of the joint. The arrow shows the dense bone at the medial aspect of the condyle that can dissipate the heavy muscle forces that are generated during function. The second function of the medial pole is to maintain the vertical dimension of the joint in terms of the occlusion. So let's talk about vertical dimension of the joint in terms of occlusion. The vertical dimension of the joint is comprised of the soft tissue, which is the disc, which is about 2 millimeters thick, and then it's comprised of the hard tissue, both the condyle and ramus, which measures typically somewhere between 60 to 70 millimeters. Increases in vertical dimension of the jaw joint can result in a class 3 bite shift, such as condylar hyperplasia, while decreases in the vertical dimension can result in a class 2 bite shift. From a clinical perspective, it's far more common to see a decrease in TM joint vertical dimension as opposed to seeing an increase in TM joint vertical dimension. Now that we have a better understanding of normal TM joint anatomy, let's take a closer look at injured temporomandibular joints. The first type of injured joint that we'll see clinically is a joint that has structural alterations at the lateral aspect of the joint. The ligament attaching the lateral aspect of the disc to the lateral pole of the condyle is torn. The ligament attaching the medial aspect of the disc to the medial pole of the condyle is still intact in these cases, and this results in a partially herniated disc. The hard tissue changes in this type of patient are variable depending upon the load that's applied to the unprotected lateral pole. Given the partially herniated soft tissue and the uncertain hard tissue anatomy in this joint, the risk profile is usually low to moderate. Now, if the condyle can position under the disc in an open view, the joint is typically said to reduce, and the disc is described as a partial disc displacement with reduction. Clinically, these patients will present with an opening click and a closing click. Now, conversely, if the disc and/or the condyle has changed shape to the extent that they don't fit each other, the joint doesn't click anymore, and the disc is described as a partial disc displacement without reduction. These types of joints typically have no pain to moderate levels of pain and usually present with stable occlusions. Now, the second type of injured joint we commonly see is a joint that has structural alterations at both the lateral and medial aspects of the joint. In these cases, the ligaments attaching the lateral and medial aspect of the disc to the condyle are torn, resulting in a completely herniated disc. The hard tissue changes in this joint are variable again, and they're dependent upon the loads that apply to the entire unprotected condylar surface. Given the completely herniated soft tissue and the uncertain hard tissue anatomy in this joint, the risk profile usually in these cases is moderate to high. Similar to lateral pole displacements, if the condyle can position under the disc in an open view, the disc is said to reduce, and the disc is described as a complete disc displacement with reduction. Clinically, these patients will present with an opening and closing click. If the disc and/or the condyle has changed shape to the extent they don't fit each other, again, there's no click, and the disc is described as a complete disc displacement without reduction. And again, these types of joints typically have no to high levels of pain, and these are the patients that have potentially unstable occlusions. Now that we know more about joint anatomy, let's revisit Tracy, the new patient in our practice, and review what we know given her history. So let's stop here and ask a couple of questions that are key to the case. From what we know so far, what do we know from the history? And the second question I'd like you to discuss among study club members is, how do high-risk joint patients present to our practice? We'll be back in a few minutes to talk further. I hope those discussions were informative among the study club members. Let's go back to Tracy's case. If we look at this case, we know Tracy used to click in the right and the left joints. Given this scenario, it would be logical to assume that the disc is non-reducing or does not click or pop anymore. So now that we know that, the goal is to determine if the disc is partially herniated with structural damage confined to the lateral pole with a moderate to low risk, or if the disc is completely herniated with structural damage both at the lateral and medial pole with a moderate to high risk profile. Since there is a grating noise in the left joint, it's likely that the disc is completely herniated. So the joint in this case is going to be tentatively diagnosed as a structurally altered joint with structural alterations at the lateral and medial pole with a moderate to high risk profile. Now the question becomes, how do these types of patients, the high-risk patients, present in our practices? And really, when it comes down to it, high-risk patients will typically present with either one of two problems, or the tough cases will have both problems. You know, the first problem we'll talk about is the one we've typically thought about TMJ patients in regards to, and that's from a pain perspective. So we can have pain in TMJ patients, and many times that pain will relate to muscle-based pain dependent upon how the teeth fit together. We can also have pain, however, from how the joints fit together. Structural changes in the soft tissue can cause herniated discs, to impinge on anatomic structures, or to displace anatomic structures. In the coronal view on the left side of the screen, the disc is herniated to the medial aspect of the joint. In the sagittal view on the right, we see a large 11 o'clock disc displacing the condyle posteriorly, resulting in a class 2 bite shift. Now, if the disc is completely herniated, the risk is going to increase for changes at the hard tissue level as well. The three main condylar changes we see are eroded condyles, small condyles, and edematous condyles. All three bone changes increase the risk of pain, similar to pain patients experience in other orthopedic joints with similar types of bone problems. While we typically think of TMJ patients as pain patients, the far more common clinical presentation of structural changes in the jaw joint will appear as some type of malocclusion. These are usually a result of structural changes of the jaw joints resulting in a decrease in the TM joint vertical dimension. There are two main types of malocclusions that occur as a result of a loss of vertical dimension. The first type of malocclusion is developmental in nature, resulting in a failure to achieve normal joint dimension. This is usually due to incomplete growth of the jaw joints due to an injury in the growing ears. The second type of malocclusion we see is a degenerative type of malocclusion, resulting in a failure to maintain a fully achieved TM joint vertical dimension. These types of cases usually occur due to an injury that occurs after growth has been completed. There are two common examples of developmental malocclusions due to injured joints in the growing ears. The first is retrognathia, which presents as poor growth of the maxilla and the mandible. As we look at Mary at 10 years, 5 months, the retrognathic appearance is obvious. She presents with significant anterior open bite at age 17 years, 7 months, and the CBCT imaging reveals a lack of growth of the left condyle. The early lack of growth evident at 10 years, 5 months gives an insight into how early this injury occurred. The incidence of early joint injuries is far greater than our profession assumes. The second clinical manifestation of joint injury in the growing patient is facial asymmetry. Deanna presents with significant facial asymmetry and a canted occlusal plane. The CBCT reveals significant injury to the left joint and the lack of both maxillary and mandibular development on the left side creates the facial asymmetry. A common joint-based malocclusion occurs when jaw joints are injured after growth is complete, resulting in degenerative changes in the jaw joints. In these cases, the joint grows to its full genetic potential and then has structural breakdown due to joint injuries. Gloria is a 62-year-old female who reports a changing bite that started after a car accident that occurred when she was 54 years old. Now, if we look at her bite, the occlusion looks great in maximum intercuspation. However, the true maxillomandibular relationship is going to be evaluated in a fully seated condylar position. In this position, we see a pretty significant uncoupling of the anterior teeth. If the uncoupling is greater than the thickness of the disc, approximately 2 millimeters, then the jaw joints are going to require further diagnostic information. When we look at the imaging in this case, the MRI reveals the loss of soft tissue and hard tissue dimension, explaining the anterior tooth uncoupling. The larger the anterior tooth uncoupling, the greater the likelihood of structurally altered TM joints, either from a failure to develop completely or a failure to maintain normal TM joint anatomy. Now, as clinicians, the question becomes, how can we confirm we're treating a high-risk patient? And really, I think the answer is direct visualization of the TM joints through MRI and CBCT is the definitive way to understand the risk factors and to be able to explain it to the patient. Mark Piper, an oral surgeon in St. Pete, Florida, developed an MRI protocol that's shown on this slide. It is designed to assess the condyle disc interface in multiple condylar positions. The 4 positions we look at are comprised of, first of all, the fully seated condylar position. The second is maximum intercuspation. The third is the incisal edge-to-edge position with midlines matching and lined up. And the final is the open position at least 25 millimeters. These bite records are sent to the imaging center so the patient can confirm these positions when the imaging is being obtained. The CBCT is going to be taken in a fully seated condylar position to allow for an accurate assessment of disc space in the joint, similar to how we looked at the occlusion in a fully seated condylar position as well. Now that we have a better idea of risk factors, let's see if we can develop a treatment plan for Tracy. Let's stop before we do that, though, and ask a couple of questions. What are the treatment planning options that we can talk about for patients with injured joints? And secondly, what are realistic expectations for occlusal appliance therapy? We'll stop here so you can discuss those questions with your study club members. When we talk about treatment options for injured jaw joints, they can be broken down into three main pathways. The first is to treat the injured joint at the tooth level. The second is to treat the injured joint at the soft tissue level in the joint. And finally, the third option is to treat the hard tissue in the jaw joint. Treatment options directed at the tooth level can be indirect options such as occlusal appliances or direct options that can change either tooth contour or position. Indirect treatment options might include occlusal appliances, chiropractic or physical therapy, medications, or we could talk about injection therapy. Direct treatment options could include reshaping or equilibrating teeth, repositioning teeth orthodontically, restoring teeth either through direct or indirect materials, or resection of the skeletal bases that hold the teeth with an orthodontic procedure. And we can use any combination of those options that we have available. The second main pathway or option we look at is to treat the soft tissue level in the jaw joint. The options in this pathway can include arthrocentesis, arthroscopy, disc repair, or disc replacement. And lastly, the third option is to treat injured joints at the hard tissue level of the TM joint. These options might include condylar reinforcement through rib grafting or joint replacement with an artificial joint. The question is, what determines the treatment? And the answer is really it's the condition of the jaw joint. So if we break this down to make it as simple as we can, if we're dealing with structurally intact or structurally altered lateral pole joints, treatment will almost always be directed to the tooth level. If we're dealing with structurally altered cases at the lateral pole and medial pole, or the high-risk joint cases, we're going to attempt to still treat at the tooth level. The key factor to understand in these cases is that we may have to consider treatment options directed at either the soft tissue or hard tissue levels of the jaw joint if we have anatomic issues such as a large and completely herniated disc in the 11 o'clock position, or if we have eroded bone, or if we have small bone, or if we have edematous bone, or again, any combination of these issues. In those types of cases, risk levels increase, and it necessitates us considering treatment options to address the anatomy at the injured joint level. Now that we know more about treatment options for injured joints, let's go back to our new patient, Tracy, and see if we can determine what type of joint she has and come up with a treatment plan for her. We gathered the following information during our clinical exam. We know that her pain has been increasing over the last 6 months. She thinks her headaches may be related to her jaw joints. She had whiplash trauma at age 20. Her average pain in the right joint is an average of 3 out of 10, and her worst pain is a 7 out of 10. Her average pain in the left joint is a 4 out of 10, and her worst pain is an 8 out of 10. If we look at her occlusion and maximum intercuspation, it looks great. The problem is her occlusion in a fully seated condylar position looks very troubling. It looks like from reading her bite that she may have lost vertical dimension in the left TM joint given her asymmetrical open bite. The bite will typically shift towards the joint with the greater loss of vertical dimension. Combining the history of grinding noise in the joints and the malocclusion, we feel more confident that our tentative diagnosis of a structurally altered joint at the lateral pole and medial pole is correct. These are the cases we'll confirm with direct visualization through CBCT and MRI imaging. If we look at Tracy's CBCT, the CBCT imaging confirms a loss of vertical dimension at the joint level. The left ramus length is significantly below average. This is a perfect example of a joint that was injured during the growing years and failed to achieve normal vertical joint dimension. The CBCT clearly shows a lack of development of the left mandible and the left maxilla. The MRI supports the findings in the CBCT. Now, if we look at the imaging, while the joint imaging reveals significant structural alterations to the jaw joints, none of the high-risk factors such as the 11 o'clock disc, small bone, eroded bone, or edematous bone were present. Given her imaging, we would talk to Tracy and explain to her that she was a moderate risk or a yellow type patient. So let's look at the treatment options and eliminate what doesn't fit for Tracy. At this point, it doesn't appear that we're going to treat at the hard tissue level, so we'll eliminate that entire column. From the soft tissue perspective, it's unlikely an arthrocentesis or an arthroscopy would help her significantly, and the disc doesn't appear that it could be repaired, so let's eliminate those options as well. The disc could be replaced, so we'll keep that as an option on board for now. In terms of treating at the tooth level, it does not appear that any direct treatment would benefit Tracy, so we'll eliminate the direct treatment options. So if we look at it, the options left on the board are indirect options at the tooth level, as well as a disc replacement at the soft tissue level. In an attempt to try and provide the most conservative treatment, we decided to begin with occlusal appliance therapy. Now, when discussing occlusal appliance therapy with patients, it's important to clearly frame the patient's expectations. Let's close our program by talking about some key points to discuss with patients when using an occlusal appliance. And I think the main purpose of an occlusal appliance, and the first thing that patients have to understand, is that it's really designed to redistribute the load between the teeth and the joints. The appliance is not designed to change structurally altered tissue or to put the disc back on top of the condyle. Another thing patients have to understand is that symptoms can decrease, they may increase, or they may remain the same when using an occlusal appliance. This is going to be primarily based upon the design of the appliance and the anatomy of the jaw joints. You'll hear a lot of discussions about anterior appliances because anterior appliances can reduce muscle forces. However, we have to understand that they may also increase the load on the jaw joints. If the jaw joints are structurally intact, an anterior appliance can be a great appliance. It can also be problematic, however, in patients who present like Laura, who have a swelling or edema in the condyle. In cases like this, in my clinical experience, a full coverage occlusal appliance is a more conservative appliance with a greater surface area to help distribute the load that's distributed. We're going to suggest to patients when they use an occlusal appliance to kind of think in a 6 to 12 month time frame to evaluate the appliance to see if we can be able to help foster some adaptation at the joint level. We need patients to understand that occlusal appliances require regularly scheduled appointments to maintain and to balance the appliance. We tell patients they can use the appliance as much as they would like, but we would like to use it when the times they put their teeth together the most, such as sleeping, driving, and exercising. And lastly, we ask the patient to brush the appliance with toothpaste and to make sure they keep it away from dogs. It sounds funny, but they smell the saliva and dogs will eat the appliance. So let's close by talking about how Tracy was treated. I inserted an occlusal appliance in her almost 4 years ago. Her headaches have resolved and her pain levels dropped from an average of 3, worst of 7, to an average of 1 and worst of 3 in the right joint, and from an average of 4 and a worst of 8 to an average of 2 and a worst of 3 in the left joint. At this joint, we adjust her occlusal appliance every 6 months during our hygiene exam, and she's been really happy with the treatment that we've been able to provide for her. So I hope this study club module has helped you understand the 3 main clinical presentations of jaw joints, as well as clearly understanding the risk factors from both soft and hard tissue changes in jaw joints. Lastly, my hope is that you will be better able to understand and discuss the treatment options for injured joints with your patients. Thanks for being a part of the Spear Study Club program, and I look forward to our next time together.